All right, and I guess we will go ahead and get started. I want to welcome everyone to Medicine Grand Rounds today. I'm very, very excited about our guest today, Dr. Jane Liebschutz, who I first met I guess most recently on as a collaborator. We worked at the Ponce Center, Dr. Del Rio, Dr. Colasante, and me on a project with Dr. Liebschutz and her colleagues when she was at Boston University looking at chronic opioid therapy in HIV patients. And it was an incredibly rich experience, and it also made it very clear to me that I was anxious to get Dr. Liebschutz down here to talk to us about opioid therapy. And she really held a lot of our hands every step of the way, sort of thinking through this project and our patient care. So Dr. Liebschutz received her medical degree at Harvard Medical School, did her residency in internal medicine and preventive medicine, as well as a Gen Med fellowship at Boston University, and was on faculty there until I believe 2017, when she was recruited to be the chief of the Division of General Internal Medicine at the University of Pittsburgh Medical Center. There she's also the Endowed Chair for Translational Medicine and Research. Her research agenda focuses on prevention and treatment of opioid use disorders, including safe opioid prescribing for pain and disseminating treatments for opioid use disorders in non-specialty medical settings. She's a national lecturer and educator on opioid prescribing. She's been a certified buprenorphine prescriber since long before many of us even knew about the drug in 2006. And she has managed many patients actively in her own practice, as well as on an inpatient addiction medicine service. So I thought this was really, as we look at the syndemics in our world that have been impacted by COVID, one that clearly we are concerned about is the opioid epidemic. And so I thought this was a fantastic opportunity to invite Dr. Liebschutz to speak to us about the opioid epidemic in the context of today. So thank you so much for joining us, Dr. Liebschutz, and let me turn it over to you.
Thank you very much. So I have no commercial disclosures or financial disclosures to make. Today, I want to talk about sort of three areas. One is I'd like, by the end of the talk, for you to understand what are the three waves of the current opioid epidemic, to make sure everybody is on the same page, identifying what is evidence-based treatment of opioid use disorder. And then the last third of the talk about the interactions between opioid use disorder and COVID. We're going to start back over 200 years ago in 1806, when a German pharmacist named Friedrich Wilhelm Adam Serturner created morphine. And its name, he named it for Morpheus, the god of sleep and dreams. And he, through experimentation with his pharmacy apprentices, discovered that 15 milligrams of this substance would be the standard dose. And today, we still use 15 milligrams as the standard dose, which had the balance between a pain relief, but not too much sedation. And you see pictures of poppy plants from which this is derived. I'm going to use a patient, Michael S., and think about him through the ages. So in 1864, Michael S. might have been a Civil War battle injured soldier, and he would have been given morphine to treat his pain. And just as an FYI, the hypodermic needle was first used in 1853, and it was created for morphine. Fast forward to 1899, and Michael S. might have had a chronic cough from industrial exposure or potentially from tuberculosis, and he would have bought diacetylmorphine from Bayer, which was felt to be a very good cough relief and less addicting than morphine. And if you see below in that quote from 1911, one of the cabinet level members of government was the Opium Commissioner of the United States. So this problem has been around for quite a long time. And this is a quote from Hamilton Wright, who is the Opium Commissioner. Of all the nations in the world, the United States consumes most habit-forming drugs per capita. opium, the most pernicious drug known to humanity, is surrounded in this country with far fewer safeguards than any other nation in Europe fences it with. China now guards it with much greater care than we do. Japan preserves her people from it far more intelligently than we do, who can buy it in almost any form in every 10th one of our drugstores. So that crisis led to the Harrison Act of 1914, which is still relevant today because the goal of the Harrison Act was to combat addictive properties of medicinal opioids, which at the time were heroin, morphine, and codeine, and to regulate non-medical opioid use. And it actually made possession without prescription illegal. And if you followed elections, the state of Oregon made decriminalized certain small possessions of small amounts of substances such as heroin, although it is still a federal crime. Just to make sure we're all on the same page, what we're talking about opioids, I want to talk about the morphine, which we heard about, which is, and the semi-synthetic derivatives. So these all come originally from the opium plant, and that includes morphine, diacetylmorphine, or we know as heroin, oxycodone, hydrocodone, hydromorphone, and oxymorphone. And then we have synthetic opioids, which include methadone, meperidine, and fentanyl. And then semi-synthetic, which derive from the poppy plant, but not from morphine. It derives from thebaine, which is another product of poppy, and that would be buprenorphine. And the reason I just bring this up, not that you have to remember any of the chemical properties, but just to remember, if you're ever checking a urine drug screen, the synthetics, methadone, meperidine, fentanyl, and also buprenorphine never will develop metabolites that include morphine, whereas all of the semi-synthetic can metabolize back to morphine. So just keeping in mind that this is semi-relevant when you're taking care of patients. So let's move fast forward to the 1960s and 1970s. Heroin was mostly located in minority communities, African-American communities, among returning Vietnam vets, and methadone was approved in 1972 as a treatment for opioid use disorder. And this is a picture of a methadone clinic. Many of them are under bridges and in really not in my backyard type of locations. So Michael S. now, he might be a returning Vietnam vet who was exposed to heroin and drugs during his deployment and is treated with methadone. I'm going to shift a little bit from the methadone to thinking about pain and opioids for pain. So in 1973 and then the 70s and 80s, a number of articles came out that suggested that we were not doing a good job treating patients with narcotic analgesics. And this is, you know, a structured interview of 37 medical inpatients, many of them with advanced cancer, suggesting that there was untreated cancer pain. And along with that came a sense that if you gave somebody with cancer pain opioids, that there was that they would not develop addiction. And this is this very famous, I don't even call article, but this very famous letter to the editor in the New England Journal in 1980 that was quoted over and over and over again, saying how addiction is rare in patients treated with narcotics. And basically it was a chart review where there were only 4 cases out of 12,000 of patients who developed addiction from opioids. So that information, that article was widely advertised by Purdue and others, saying that if you treat patients with opioids, particularly with this new compound named OxyContin, it will help address the undertreatment of pain. And you could see the 2001 Joint Commission said pain is a 5th vital sign. So you had to be assessing and treating pain. And this article from 2006 shows the marked rise. You could see this dark dotted line of pain reliever prescriptions between 1965 and 2001, really, you know, multifold increase. And also you get sedatives had increased significantly, but really the opioids were markedly increased. So in 1997, who is Michael S.? He is somebody who's got chronic pain from construction accident. He's on disability, and he was prescribed oxycodone to help with his pain. So we saw that rise in opioid prescriptions, and you can see in this chart here, this rise from 1999, to the 2010s, marked increase of kilograms per 10,000 people from a little bit under 2 to over 7. And concomitantly see this is OPR, stands for opioid pain reliever, overdose deaths per 100,000, went from 1.4 up to close to 5. The treatment admissions in drug treatment programs markedly increased. And then you see a little bit of a lag, but then you see the neonatal abstinence syndrome NICU admissions per 1,000. So like marked increase of the side effects of opioid pain relievers. And just a quick note here about MED. So MED stands for morphine equivalent dose. And so, and I'm not going to get into how that's derived, but basically all opioids have some sort of calculation about how they are equivalent to morphine. And what we know is that people prescribed higher doses of opioids had a higher risk for fatal overdose. And so that's just something to keep in the back of your mind. We also saw in the 90s and really the 2000s, what we call pill mills, which is a small number of physicians nationally prescribing an outsized number of pills. And they would be, and you could see this is a picture outside such a clinic in South Florida. So then what happens, so that's wave 1 that we just talked about. And then wave 2 starts in 2010 when heroin is on the rise. And you can see this chart here in the, I don't know if you can see my pointer here, but you can see the blue line of prescription opioids. And this is a line of overdose deaths per 100,000 population. And you see climbing to the 2000, maybe leveling off a bit. But then what you see starting in 2010 is a slow and steady and marked increase in heroin-related overdoses. So what happened with this? States and physicians were becoming aware of the opioid prescription problem, and were leveling off the number of opioid prescriptions. And then what you see is heroin on the rise. And this is really imported from Mexican cartels. And these cartels were really smart. Instead of using big drug dealers in the cities, they now started to market directly to suburban white customers. And if you haven't read this book, Dreamland by Sam Quinones, I highly recommend it. Really interesting, easy read, nonfiction, looking at this epidemic. All right, so then what happened? Heroin use climbed and then eventually stabilized in the mid-2010s. So you can see in 2002, of the National Drug Use Survey of Households, there was about 400,000 people reported past year use, and then in the mid-2010s, it's more closer to 1 million, 900,000. And you can see here the heroin deaths by these figures. The little person is approximately 2,000 heroin deaths in 2002, up to almost 16,000 in 2017. So it increased 7-fold. So in 2010, Michael S. was an unemployed coal miner. When his OxyContin supply was cut off, he started buying heroin, injecting 3 to 4 times a day. He's had 2 overdoses, which were reversed. His girlfriend is a nurse, and he watches the kids when his girlfriend works. And these are actually real, that is actually a real patient that I've taken care of. All right, so the third wave of the opioid epidemic happened starting in the mid 2010s when fentanyl came on the market. So fentanyl is 50 times more potent than heroin per milligram. It's manufactured in China and elsewhere and imported. And because it's so strong, it's really easy to hide and import in small doses. It's mixed with heroin and other drugs to increase the high. And so it's 100 times more potent than morphine, 50 times more potent than heroin. So in 2016, Michael S. had multiple non-fatal overdoses. There were no treatment slots in his rural county, and he died of a fentanyl overdose. So I have data here from 2018, and that's the most recent data we have. And because the data, in fact, we don't have 2019 data from the CDC, and I don't know, there are probably people who work at the CDC on this grand rounds, but it takes a really long time to cull through and get accurate data and put it together. So we're sort of a little bit uncertain what was 2019 and even more so for 2020, but I'm going to present some data about 2020 in a little while. All right, so there were 67,367 drug overdose deaths in 2018, which was slightly down from 2017. And of those, almost 47,000 were from opioids. And if you look at this graph here, you can see that blue line is synthetic opioids other than methadone. So this is really fentanyl and fentanyl analogs that are there. And you can see in about 2013, 2014, it really took off exponentially for being the cause of drug overdoses. But you can also see heroin, which is sort of this dark olive green line, also sort of, this is the 2010 taken off. And then this kind of golf course green line, I would say, this one here is the painkillers, natural and semi-synthetic opioids, which sort of starting to level off, although still increasing a little bit. So you've got this triple whammy of these different kinds of opioids causing death. I looked up data for Georgia, and there were 1,400 overdose deaths in 2018, which was 13.2 per 100,000. I'm just going to talk a little bit about opioid pain relievers, just a few slides. I could go in great depth, but I want to save time for other things. So just the first issue is, are opioids efficacious for chronic pain? And many of us hold it out as the top of the World Health Organization, pain ladder and other things, as if these are the be all and end all for pain. Now, opioids are very useful in acute pain, particularly surgical post-operative pain, surgical pain. As for chronic pain, for some people, for sure, they help. This was a meta-analysis published 10 years ago now, where they were only able to find 2 high-quality studies. And in those studies, there was follow-up of about 7.5 months up to about a year. And they found that of the participants, a little bit less than half, 44% of participants, had at least 50% pain relief. So opioids, certainly are helpful for a portion, but not everybody gets at least 50% pain relief with them. This other study, the SPACE trial, which was published a couple years ago now in JAMA, was a trial where it compared opioid and non-opioid pain ladder. And patients, this is a VA study, and it was a collaborative care model where they had a pharmacist who was heavily involved in the patient care. And what they looked at was baseline 6 months and 12-month scale on the brief pain inventory function. And what you can see is that these 2 groups were similar, basically. The opioid and non-opioid had the same efficacy for pain. This doesn't say that opioids are not efficacious. They're just as efficacious as non-opioids, and non-opioids are as efficacious as opioids. So I think that we have to get rid of this idea that opioids are the be-all and end-all for pain. They're just one piece of the armamentarium. this is a little bit complicated, but I feel that if I'm presenting to, and I assume many of you are internal medicine residents out there who are taking care of patients in the hospital or hospitalists, I think this is a really important concept and a little bit complicated. But this is a study, and I'll present another study on the next slide, looking at what is the impact of having an opioid prescription when you get discharged from the hospital on long-term opioid use period of time later. So this was a study, and this was an observational study of over 6,000 patients in Denver, University of Colorado. And they looked at the medical records. All of these patients were opioid naive when they were hospitalized, meaning they had no opioid prescription for a year prior to their hospitalization. And there were 5,001 who were not given a prescription at discharge. And of that group, about 1% was prescribed a chronic opioid at 1 year. There were 1,688 patients who received a prescription at discharge. So it's 25% of the whole discharge group. And of that, 70 or 4.1% had a risk of, I should say 12-month risk of chronic opioid therapy. So, you know, again, the numbers are small. It's only 1% and 4%. Nonetheless, that is a fair, you know, if you translate that into all the patients that get discharged from the hospital, that's a fair amount of people for whom a discharge at, you know, at the time of hospitalization leads to chronic opioid therapy. And this other study actually was conducted at UPMC, where I'm on faculty and practice medicine. And this took 191,000 UPMC admissions. 50% were 50% of opioid naive patients received opioids while they were hospitalized. And you could see on this graph here, and it may be hard to see, but the triangle is, the green triangle is people who are in surgery, who are in the non-ICU. The upside down triangle is the patients from surgical service who had an ICU. And then the other two are medical, non-ICU and ICU. And you can see this is when did the opioids end. So this is 0 to 3 hours prior to discharge versus 72 hours prior to discharge. So, you know, a lot of patients were getting opioids, you know, the half a day or the day prior to discharge. And that's sort of relevant when we look at the next slide. And I'll just tell you, this is, this group here had, this group here, looking at 90-day versus and 365-day opioid use. And this is the percent of patients. So if you did not have, you were not prescribed opioids as an inpatient, 3% had an opioid prescription at 90 days, and 4.3% had an opioid prescription at 1 year. If you were given opioids as an inpatient, it's almost doubled, 5.9% at 90 days and 7.7% at 1 year. And these were controlled for all sorts of things. And I'm not showing you the difference. I'm not showing you this analysis, but there was a close analysis between whether you received a opioid in the hospital just prior to discharge and your risk of having opioids later. So we just need to be really careful stewards of prescribing well in the hospital, and be careful of stopping them and switching to non-opioids when we, you know, when we think the patient doesn't need it. There's a habit of just leaving the orders on the chart for days and days. And then the last thing related to opioid prescribing I want to talk about is opioid prescribing after overdoses. So this was a study that my mentee and I published, Mark LaRochelle, who's at BU, and we looked at patients. This is a huge database, Optum database, where there are, you know, thousands of patients. And we looked at patients who had a non-fatal overdose who had been prescribed opioids in the 60 days prior to the overdose, and what they were and what happened afterward. So time 0 is when they had their overdose. And you can see about a third were non-fatal. 25% were non-fatal, and 7% were fatal. And this is the percent of patients who were on high doses. Remember I mentioned that 100 milligram MED. About a quarter were moderate doses, 50 to 100, and then about a third were 25% had low dose. And what you can see is that afterward, about 75% of the sample were still getting opioids despite having had an overdose. And what this graph doesn't show is that at any point, 90% of them, at some point, 90% of them had a subsequent opioid prescription. So again, we need to be very careful when somebody has an overdose or a signal that there's a problem, then we should be careful about subsequent prescribing. All right, I'm gonna now turn my attention to opioid use disorder. And I'm sure many of you already know this, but I will just review. So what is addiction? It's a brain disease. Drugs hijack the brain reward circuits, and through that we develop tolerance and withdrawal. It's also a learned behavior, a habit. So it's not just that your brain cells, crave the drug, which they do, but it's also that you've developed habits and ways of being and interacting in the world that reinforces the brain response to drugs. Just reviewing the DSM-5 criteria so that everybody, we're all on the same page. So there's a number of criteria, and you need 2 of these criteria to get at least mild opioid use disorder. So what are they? Using in larger amounts or over a longer period than intended, unsuccessful efforts to cut down or to have persistent use, a great deal of time spent getting, using, or recovering from use, craving or strong desire to use, recurrent use resulting in failure to fulfill major obligations at work, school, or home, continued use despite personal or inter problems caused by use, social work or recreational activities given up or reduced, use in situations in which it is physically hazardous, such as driving or operating machinery, continued use despite physical or psychological harm, and we often see that in hospitalized patients who've had consequences and continue to use. And then there's the classic opioid withdrawal and tolerance. So you have withdrawal that we all know about. Many patients or individuals who have opioid use disorder don't ever allow themselves to get into withdrawal because they feed the habit by using opioids to prevent withdrawal. And then tolerance is need for an increased amount to achieve the same effect or decreased effect with the same amount. Now, many people use the word drug abuse or opioid abuse. That lingo is not current. And really what you should think about is mild, moderate, or severe substance use or opioid use disorder. And this goes for alcohol and cocaine and all the substances. So 2 to 3 of those, 2 to 3 of those criteria would be mild, 4 to 5 could be moderate, and 6 or more is severe opioid use disorder. So I'm going to spend just a couple minutes talking about medications, and I'm not going to spend any time about behavioral therapies because there's no evidence that they work for opioid use disorder. They may help in other areas of patients' lives, but they don't actually prevent substance use. And then self-help, there is some observational data that AA and other meetings may be helpful, but they may be helpful for some and not others. But let's focus now on medications. So there are 3 approved medications, FDA-approved medications for opioid use disorder, and they include the full agonist methadone, the partial agonist buprenorphine, often known as Suboxone, and then naltrexone and the injectable form of Vivitrol. Morphine is approved in Canada and Europe for treatment of opioid use disorder. Just a visual reminder, I love this chart. It's 17 years old now, but really gives you a sense of the severity and withdrawal of the different substances. So heroin gives you a very intense withdrawal that peaks at about 4 days and is pretty much over by a week. Whereas buprenorphine has a slightly longer duration, but the peak is not as bad for the severity withdrawal. And then methadone, which can go on for very long periods of time, which also is not as bad as heroin, but really problematic for individuals who have high doses of methadone and need to come off of it. So what are the clinical settings in which these evidence-based medicines can be prescribed? So the first, methadone, as I mentioned, it was approved in the early 70s, and it can be only distributed at federally licensed facilities. And they have daily observed dosing and very tightly prescribed regulations about that. And I'll talk a little bit more about that when I talk towards the end of my hour about what's changed in the COVID pandemic. Buprenorphine is a partial agonist, and it can be given in any outpatient setting, and it requires a special DEA waiver for outpatients, and you can get up to a 30-day supply, so you don't need to come in every day when you first start out the way you do with methadone. And then naltrexone is a pure antagonist. Any licensed prescriber, you don't need a special waiver. You can take it orally, and it also has a 4-week injectable, and this is also approved for alcohol use disorder. All right, so just again, many of you work on the inpatient service, and you don't need any special license or to prescribe methadone and buprenorphine if it is complicating the inpatient medical treatment, even if the patient is not planning to continue on afterward, or you don't necessarily know where you're going to be. And my recommendations are, for methadone, you really don't get higher than 40 milligrams a day for the patient. And you remember that chart I showed you about how long it takes for the methadone to wear off. Once you get higher doses, then you are going to cause higher withdrawal or more prolonged withdrawal. And then buprenorphine, anywhere from 2 to 16 milligrams a day. The caveat for buprenorphine, it's a partial agonist. And so if somebody still has opioids in their system, or they're high on opioids, or they're getting opioid pain medication, the buprenorphine can precipitate withdrawal. So you need to be careful with that. So why am I focusing so much on methadone and buprenorphine? I'm showing here all-cause mortality rates in and out of substitution treatment. And it's a bit of a complicated visual. So I kind of put the bottom line here on the left. But what you can see here, these are 2 meta-analyses, one of methadone and one of buprenorphine. And when you look at both, and you see the blocks over here, that when somebody is in treatment with methadone, their risk of all-cause mortality, not just overdose, is 11 per 1,000 person years on treatment, and it more than triples to 36 per 1,000 person years not out of treatment. And buprenorphine, it's slightly better, but again, you see a 2 to 1. So 4.3 all-cause mortality rate per 1,000 person years versus 9.5 out of buprenorphine treatment, or in the placebo-controlled trials on the placebo. So we really know that these are life-saving medicines, and if we had anything like this in cardiology, we would be all over it, but we do have it in addiction, and we should be using it. Okay. This is a study that I was part of with, again, my same mentee, Mark LaRochelle, and we looked at observational data. This is an amazing data set where it takes the entire population of Massachusetts and puts in all the data, all the death data, all the medical data, hospital rides, substance treatment data, and puts it together, and you can analyze it. And what we did was we looked for all the patients who had a non-fatal overdose, and they were touched somewhere in the system, whether it's ambulance, EMS, or hospitalization or emergency room. And we looked at what the risk for fatal overdose was in the period after the overdose. And what we found is that both methadone and buprenorphine have a hazard ratio of 0.3 likelihood of subsequent fatal overdose, compared to naltrexone, which did not have a significant improvement. It suggested it, but did not have a significant improvement in subsequent mortality. And part of it is that people did not stay on this naltrexone for very long. So it's a little bit hard to tell. And there's a suggestion in the literature that potentially in the post naltrexone period, the overdose rates were higher. And we're doing analyses now, sort of teasing that out. The average length of time on buprenorphine was 4 months. The average length of time on methadone was 5 months. So these are patients who had a non-fatal overdose, who were put on treatment and had improvement, but disappointing length of time on therapy. So now at the last part of my talk, I want to talk about opioid use disorder and COVID-19. And there's 4 points I'm going to talk about, both that opioid use disorder increases the risk for infection and worse COVID outcomes. There's hints and suggestions that we have worse opioid use disorder outcomes in this epidemic, and the impact of and the fact of expanded treatment. So this was a study of 73 million unique patients. One of the co-authors on this study was Nora Volkow, who's the head of National Institute on Drug Abuse. And what it looked at was, and this is the top one, substance use disorder, the risk between having a recent substance use disorder and COVID-19. So what you see here is that the risk was 8.7 and highly significant. Of course, in 73 million, anything is going to be highly significant. But really, having a recent substance use disorder increased your risk of being diagnosed with COVID-19 eightfold. And the alcohol use disorder, cocaine use disorder, cannabis use disorder, all were slightly less than that. But you look at opioid use disorder and it's 10, the odds ratio is over 10. So this is really quite a big risk factor for developing, and this is controlling for all sorts of other risk factors. I'm going to show you the next slide from the same study, which not only looked at the risk for, but also the risk for mortality from COVID among substance use disorders. And I took this slide directly from the paper, so I'm just going to orient to you. The paper also, and it's really worthwhile reading, compared African American and Caucasian, because we do know that being African American increased the negative risks for death rate among patients with COVID-19. But what you see here is these are patients with COVID-19 who do not have a history or current substance use disorder. And the odds ratio, which we all know, is higher in African Americans. But let's just follow the orange line first, which is Caucasian. And you can see if you have any history of substance use disorder in your record, your percentage goes from 6% up to over 8% of being diagnosed with COVID. And then if you have recent past 12 months substance use disorder in your record, it goes almost to 10%. So just having substance use disorder diagnosis is an increased risk for getting COVID. And you can see among African Americans, that risk also markedly goes up from 7 to 13. And it's not really different between recent and past in that group. And also recent is not, the differences for African American and Caucasian are not different, but it's pretty astounding what this risk is. And we saw earlier that, well, I'll say this first. So why the increase in death rate? So what we know is that patients with substance use disorder have higher prevalence of chronic diseases such as kidney, liver, lung, cardiovascular. They have higher rates of type 2 diabetes, obesity, and cancer. And much of this can be linked to the cigarette smoking that goes along with having other substance use disorders. But the one thing that was really interesting is we saw that opioid use disorder had a much higher and specific risk that's distinct from other substance use disorders, but none of these other underlying conditions of chronic diseases were different in that group. So we don't 100% understand yet why opioid use disorder confers such a higher risk of developing COVID. I'm going to shift gears a little bit. Maybe Wendy Armstrong or Carlos Del Rio might comment on that when I'm done about why that might be. All right, so worse opioid use disorder outcomes. So when I showed you the slides earlier about the opioid epidemic, I showed you data that the most recent data was from 2018. So we really don't have clear data about opioid fatalities from opioid overdose and other opioid negative opioid outcomes. So I'm going to show you the data that we do have that hints at some of these issues. So the first study I'm going to show you is, again, I'm sorry, it's a very complicated slide, but I'll walk you through it. So this was Quest Diagnostics did analysis of urine drug screens. And what they did was they compared outcomes from January 1st to March 14th versus March 15th to May 16th. And the first thing I'll do is point you to look at the bottom of the graph and look at the numbers. So before COVID, again, it's a little bit of a longer time period, but you know, many-fold higher number of, N is the number of urines that were tested for these substances. So many-fold higher numbers that were tested than in the COVID period. And that's just because many fewer people were getting urine drug screens tested and sent for obvious reasons. But now I want you to look at the positivity rate. Maybe we'll go up to this chart here and you can see what I circled. So fentanyl went from 4.3 to 5.8 positivity rate, heroin 0.9 to 1.3% positivity rate, and opiates 6.1 to 6.7. Marijuana was also increased 16.4 to 17.0. But you look at these other substances, cocaine, amphetamines, oxycodone, and tramadol, there was no difference in positivity rate. And then in gabapentin and benzodiazepine, actually the rates of positivity went down. So you might say, like, why was this? Were these just, you know, people with opioid use disorder who are getting more drug screens? Well, what they show is that most of the drug screens that occurred, the percent of those from substance use treatment programs went way down. So these are people who are not in substance use treatment programs and for which the rate is higher. So this suggests that potentially this is a signal that there is more opioid use disorder going on. And this is further analysis of the same data, which shows for male, again, the positivity rate went up significantly, female just slightly, but in each age group, it also went up. There was no exception to that. And now I'm going to show you data from a syringe exchange program in Pittsburgh. I'm on the board of this. It's called Prevention Point Pittsburgh. And we just shared this data the other day, and I asked if I could use it. So I'm going to show you first on the left diagram. So this is the annual number of syringes distributed by Prevention Point Pittsburgh. So 4 years ago, it was 2016. And then as of the end of September, it was already had well surpassed that of 2019. So over 700,000 in 2019 and 9 months of the year. And what you can see on the right is you can see in each quarter, you could see the market increase in syringes from 191,000, that's the gray line, up to 297,000. And the number of visits, so site visits would be individuals, and in the blue and in the orange would be people were picking up for other people. So really astonishing increase in individuals seeking treatment. And that's a picture of the van on the bottom there. This is another study, and this study was out of Virginia Commonwealth University, and they looked in changes in ED presentations March to June 2019 compared to the same period in 2020. And first look at the graph on the right, and what you see is that the number of ED visits went from over 35,000 down to about 25,000 over the same period, over year. So the total ED visits went down, and the graph on the left, the myocardial infarction visits also went down, I think from 40-something to 30-something. But look at the non-fatal opioid overdose. Went over over 100% increase. So from about 100 to about 225. So really, there's a signal here that we're going to find more and more data when it fully comes to fruition. And then this other study, again, is very complex, but I think it's quite interesting. If you look at Kentucky EMS opioid overdose runs. So first of all, the graph on the left is the number of opioid overdose runs. And you can see in this interrupted time series between, it was pretty steady until the beginning of March. And then starting like mid-March, it has a slow increase, steady increase and what on average, a sustained increase of, I have my data here, of 1 additional overdose per day. And that adds up over time. The chart on the right is also quite interesting because this is patients who are called for an overdose and the EMS comes there and revives them with naloxone, but then the patients will refuse transportation to the emergency room. And if you look in non-opioid overdose, there was really no difference over time. But in the opioid overdose, once the state of emergency was declared in mid-March, a much higher rate of refusal from less than 5% to 8%. Now I know it sounds, or the number of runs that were different. So again, you can see a real market difference in behavior, and that is worrisome for what we're going to find on the other end when we get all the data together. Why is it that we might see increases in use and overdose? So in terms of overdose, with the social distancing measures, people are using alone a lot more, and there may be no one to find them when they're overdosed. Like people are not going into the restroom in McDonald's and overdose. I've seen as much. They're overdosing by themselves. There's also been disruption in the sources of drug use, and that could be from purchasing from unknown source that may be mixed with fentanyl or cut with other, other substances that people don't know. There's been a marked rise in mental health symptoms that we know, which may lead to intentional overdoses or intentional drug use that leads to an overdose. A lot of early release from incarceration without a concomitant increase in referral to substance use programs. And then a disruption from substance use programs and decreased access for new patients. This is a study from 2017. One of the things we need to think about is unemployment. And this was well before any epidemic or pandemic, which is as the county unemployment rate increases by 1 percentage point, the opioid death rate per 100,000 rises by 0.19 or 3.6%. And the opioid overdose ED visit rate per 100,000 increases by 0.95 or 7%. And what's interesting about this study, and again, I'm not any health economist, is that the findings hold when performing a state level analysis rather than county level, but because people live in their micro environment, that this county unemployment rate is really quite relevant and driven by adverse events. And it's stable across time periods, this relationship. So I think that we really are going to be seeing some scary numbers with the high levels of unemployment we have now. So the last part of my talk, I want to talk about expanded treatment access. And SAMHSA is the Substance Abuse Mental Health Service Administration, which is the federal branch of the federal government, which promotes a lot of the regulations around methadone and buprenorphine prescribing and drug treatment. So in terms of buprenorphine, on March 20th, the SAMHSA allowed video visits for new patient start for prescribing buprenorphine. And prior to that, it was required an in-person visit. So this was the first release. And then about 10 days later, they changed and said, well, you can allow a telephone-only encounter if you don't have video visits. Methadone, the rules also changed. They're very prescriptive rules state, federal rules and some state rules around how many take-home doses individual clients can have. And basically, this markedly increased the take-home doses and eschewed the rules for when take-home doses can be prescribed. So this really changed things. And I don't think I have a slide about it, but there's some preliminary data that there's been no market increase in methadone overdoses because of this. I'm giving you some data. I didn't update this. I did this for a talk in June, but I think it's pretty relevant and interesting. So this is our group. In the dark purple are face-to-face visits, and in the orange are telemedicine virtual visits. And what you see is our numbers in January and February, 100% face-to-face. In March, we started some telemedicine, and then we basically went all virtual in April and May. And what you can see there is that the number of visits went markedly up, and it's only gone up since then. And in this next slide, you can just see here, our number of patients went from 193 up to 228 over those period of time. And so we really increased our capacity by having telemedicine. And as somebody who practices, what's great about telemedicine is I have some things that I put in. So some really big advantages are the patient can't tell you they can't come in because they can't get there, because you can just see it. You also can see patients in their home environment on telemedicine. I have a patient, actually I have a mother-daughter pair who are both my patients, and I see them individually on telemedicine, but they both light up cigarettes when I'm talking to them. And one of them is pregnant, and it sort of drives me batty because I've never in my entire career had a patient visit where the patient was smoking in front of me. So that's kind of interesting. You can have frequent visits. So I have a couple of very complex patients for whom I can have weekly, 10 or 15-minute telemedicine visits, whereas it would have been really hard to get them to come in for weekly visits in person. And it's a wider catchment area for patients, particularly in areas like Pittsburgh or maybe Atlanta, where people may live farther out and not have access nearer to where they live. Disadvantages, not all patients have smartphones with minutes. There may be privacy issues depending on where people are living or staying. It's a complex technology to maneuver. You can't do urine drug screens over the phone, although there are many Quest diagnostic or other similar that you can send people to. And you can't give the injectable, the long-acting buprenorphine or naltrexone. They have to come in for those. So I have basically want to summarize the things I talked about, and then we have 5 minutes for comments or questions. So the first point is there's been a balance between therapeutic use of opioids and addiction for centuries. We know that medication treatment saves lives, and we know that opioid use disorder increases risk and seems to worsen outcomes in COVID. The opioid use disorder prevalent and outcomes appear worse in COVID, although we won't get the full reckoning for a while. And then these regulatory changes in medications for opioid disorder may improve access if they're able to stay long-term and not just in the period of the pandemic. So thank you very much, and I'd be pleased to take comments or questions.
Thank you so much, Jane, for that really fantastic talk. And I actually have a ton of questions I could ask you, but I'm going to start with the ones in the chat box. Here's a couple that are shorter, because then there's a couple that are longer. Is there, you mentioned sort of following or looking at patients who had a history of opioid overdose and factoring that into your prescribing. Is there an ICD-10 diagnosis for the history of opioid overdose, accidental or intentional? It's not often something you find in problem lists to sort out.
I think that there is. I don't know it offhand, but I will. Yeah, I don't know the answer is, but I'm pretty sure I'm pretty sure that there is. And that if not, we should put it in their problem list. Yeah.
Another question, do you know if large organizations like SAMHSA have plans to remove the word abuse from their name, since we are moving away from this type of language?
There is, I don't know about SAMHSA, but the National Institute on Drug Abuse has been dealing with for a very long time. And I don't know, Carlos may know more. He's on the NIDA Council. But personally, I think they should say drug addiction, take the A and put addiction. But of course, it's also drug use. So yeah, that's a great question. Yeah, what else?
Dr. Colasanti asked a question. In the HIV field, we've largely moved to a test and treat approach where we start antiretroviral therapy on the day of diagnosis. Are we moving in that direction for opioid use disorder?
So I'm not exactly sure. So I totally, and I had other data that I've presented before, but I took out for time. There is a lot of evidence that starting individuals in the hospital, in the ED, will increase their ability to connect with subsequent substance use treatment. And you remember that slide that I showed, that when people are on treatment, it decreases the risk of fatal overdose. It's by 2/3. And so anytime you can get people on treatment is great. One of the issues is keeping people in treatment. And that is one of the bugaboos that we have to solve in the substance use treatment field. But yeah.
If you guys solve that one for us in substance use treatment, we'll use it in HIV. Thank you. All right. So here's, I think the million-dollar question, which is raised. This physician says, I was recently doing a morbidity review for a patient who developed toxicity with their morphine PCA, and the palliative care folks said, we have a greater responsibility for getting our patients out of pain quickly. How do we navigate this thinking of management of pain with less attention to dependence, tolerance, and possibility of substance use disorder while still efficaciously managing severe pain in the hospital? How do you balance those?
I think that it's a really tough one. I think that probably, I don't disagree in some ways with the palliative care that we do have responsibility to really focus in on pain. I think we often, I'm thinking of patients who come in with substance use disorder. We often undertreat pain because we're afraid of giving people an addiction. So I'm not that worried about treating pain. What I always say is, if the patient is sitting up and talking to you, then you're not overdosing them on pain med, because you want to get them comfortable on pain med. On the other hand, we really have to be judicious about what we do as the pain starts to get relieved, and how we manage them, and whether we discharge patients on pain medication. And if we do, what expectations we give to them about it. Now, somebody who's got, you have to look at the whole patient. Somebody who has severe end-stage XYZ disease, probably going to be looked at a little bit differently than a young person who's likely to fully recover from whatever disease or problem they have. And you don't want to give them a second problem of opioid, dependence by giving too much opioids. And then we also, I think, don't give topicals. We don't give other non-opioid medications enough. And then I guess I said this already, but I'll say it again, which is managing patient expectations for pain. I think if we can help people, pain is just a sensation, and suffering is really the mentality that you have around it. And so I think working around expectations to help with is really useful, and sort of giving expectancies for what to expect over time for patients. That would be really, really important.
I know you've taught me a lot about sort of expectations and multimodality therapy, and really taking the time that it takes with patients to help get to the relationship and the outcome that you're hoping for. Last question, can you kindly comment on using methadone for sleep? Are we creating a potential addiction?
I would never, ever use methadone for sleep. That is not, no. I mean, you're basically have the potential for causing central sleep apnea and sleep. It's not a sleep medication. It's, it really should be for pain or for opioid use disorder. So no methadone for sleep. So.
All right. Well, we are at the top of the hour. I want to again thank you so much for beaming down to us and for this talk today, which I think was really fantastic.
Thank you. I hope to come back soon and see everybody. Hi, everybody from Grady.
We'd love to see you in real life.
Thank you.
Me too.